Okay, hello everyone. Welcome to our presentation. I'm Dr. Reem Sairafi, and I will be conducting the first session of our Endodontic Journal Club. For this literature review session, where I have selected the most interesting articles from the 2020 journals, and I will be discussing and analyzing the selected articles in full detail. The first article for this presentation is the paper published by Zimmerman and Nosrat in January 2020 Journal of Endodontics. And this article adds a new perspective to the field of regenerative endodontics. If we look at the keywords, Senos was included, which clearly explained where the biologically based approach coming from. It's the new collagen-based scaffold and is composed of calcium phosphate-based mineral particles with a carbonate peptide structure combined with both-in-one collagen. In the introduction, the author referred to the previous work that used the engineering strategies in regenerating the pulp-dentin complex. This was both in animal and human models. Also, they referred to the advantages of the regenerative endodontic treatment in root development and the potential reinforcement of the root structure in comparison with the Apexification technique. Also, in the introduction, they referred to the previous work of Nathas and Zimmerman in 2015, where they showed successful outcome for immature teeth treated with Sonos putty as a scaffold. And these findings were recently confirmed in another histological study carried by Nusrat in 2019 in non-infected immature teeth using the same scaffold, the Sonos putty. And they documented that the remodeling of the scaffold particles in the cementum-like mineralized tissues that caused with the newly formed mineralized tissues on the dentinal wall. Now, the rationale of or behind this study, there is no consensus in using this technique, or in another word, the regenerative endodontic treatment, to treat the previously treated open apex teeth. And their aim was to report on long-term clinical and radiographical outcomes of regenerative endodontic treatment in previously treated immature teeth using the Sonos putty as the scaffold. This case series, including patients who had immature teeth with failed previous root canal treatment, where the apical diameter of the teeth was measured using the cone beam computed tomographic imaging to confirm a minimum apical opening of 1 millimeter. The patient in this study, actually there were 4 patients from 14 to 46. 2 teeth were diagnosed with acute apical abscesses, 2 teeth with asymptomatic apical periodontitis, and 1 tooth with a chronic apical abscess. The greatest apical diameter, as I just mentioned, all were measured in the preoperative with the cone beam CT scan in either a sagittal or a coronal section, whichever was greater. Now, in the material method, during the first method, the previous root canal filling was removed using the headstone file or by heat generated through the heat carriers. And again, another important point, there was no chemical solvent during the retreatment procedure. All the canals were irrigated with 6% sodium hypochlorite, with the use of the macrocannula of the endofac system. And then a creamy mixture of double antibiotic paste was prepared by mixing vaccine and metronidazole powder with saline. And an incision and drainage procedure was performed in case number 1 to treat the localized swelling in the vestibule. The patient was given a prescription for amoxicillin every 8 hours for 10 days. Now, the second visit, all patients returned 4 weeks after the initial visit and were asymptomatic. Local anesthesia was given using the bupivacaine 3%, and the antibiotic paste was removed using the 17-ethylene diamine tetraacetic acid with the endovacaine microcannula over 5 minutes. Bleeding was induced into the root canals by overextending a curved hand file size 30 into the periapical tissues. Sinus putty was placed in the root canal orifices and packed apically using a plugger, and then the bioceramic putty was placed over the sinus putty and was adapted apically and laterally. A wet sterile sponge was placed, and this was followed by cavite temporary restoration. All this was during the second visit. In the third visit, the patient came after 7 days, where both the cavite and the sponge were removed, and the setting of the BC putty was confirmed. And then finally, a layer of glass ionomer was placed over the set putty, and the tooth was restored with the composite restoration. Now, the recall period, all the patients go through a recall period range from 20 to 72 months with an average of 54.4 months, where clinical examination and radiographic examination were carried out using the periodic radiographs and, if possible, with cone beam CT scan imaging. They looked at the healing of the following criteria: healing of periapical lesion, root development, and the mineralization of the root canal space. And the treatment was considered successful if the tooth was functional and asymptomatic, and all the periodontal findings should be within normal limit with the healing or the heal of the periapical lesion. Now, if we look at the periapical preoperative and the post-operative radiograph, and even the sagittal and the coronal sections of the cone beam CT scan, was the first case. It shows the preoperative and the post-operative radiograph. If you look at the A, B, C, and D, all these are the periapical radiograph, preoperative and the post-operative, while the E1, E2 is the sagittal cone beam CT scan sections, showing the healing of the periapical lesion and the intraradicular partial mineralization. F1 and F2 again showing the sagittal sections of the tooth number 9. Again, it shows the healing of periapical lesion with partial intracanal mineralization. This is the periapical, preoperative and postoperative, and even the sagittal section of the case number 2, or the second patient, where we can see again the healing of the periapical area and the complete closure and the complete intracanal mineralization. This is the case of the third patient. Again, we can see here a partial intracanal mineralization with the healing of periapical area through the preoperative and postoperative periapical and the postoperative sagittal section. And this is the case of tooth number 31 of the first patient. Again, it shows how the preoperative and the postoperative images, and the sagittal coronal section showing again the healing of the periapical area and the partial intracanal mineralization. Now, achieving optimal disinfection of the root canal system is a major challenge, especially in the regenerative endodontic treatment. And we have to really worry about if there is any residual bacteria that had a negative impact. And this can be reflected in the form of a lack of the radiographic root development. And it was revealed that teeth with a history of pulp necrosis for an extended period of time, it can affect the radiographical root development. And this could be related to the difficulty in removing the established bacterial biofilm. Again, this should be the bacterial diversity of the retreatment cases should be considered, especially the bacteria that involved in the failed root canal treatment are less diverse compared with the primary infection and even more likely to be gram-positive, which is not really the case in the primary infection where there is mainly negative anaerobic species. Now, clinically, the bacteria could be, the anaerobic species are more susceptible to the sodium hypochlorite, which is not really the case with the facultative species where they have more resistance to the antimicrobial root canal area. Now, the choice not to use any chemical solvent, if you can still remember where I was talking about the material and method section where they use no any solvent, because their concern was about the cytotoxicity. The effect of the solvent, if being used, the chemical solvent, they might have an effect on the proliferation and the attachment and the differentiation of the stem cells, and even on the dentinal walls. Also, it is not known if residual toxic effect of the solvent on the stem cell may occur after the use of these solvent. The use of putty or the BC putty as the coronal plug over the Senos putty and blood was easier to handle and doesn't discolor the tooth. Bioactive cements create a layer of hydroxide crystal at their interface with the biological environment, all together make them biocompatible. In conclusion, the present case series recommend that regenerative endodontic treatment might be a viable option for the retreatment of immature teeth. This article adds a new perspective to the field of regenerative endodontics. However, we need more clinical studies with larger sample sizes to determine the success and the survival rate of the previously treated teeth undergoing regenerative endodontic treatment. Okay, now we are moving to the second article for this presentation. Now, what attracted my attention is the inflammatory blood. When I went through the title, which is the effect of the periapical inflammatory blood on dental pulp regeneration, a histological in vivo study, which was published by Zaki et al. Again in January 2020 Journal of Endodontics. According to their definition, inflammatory plaque is an exaggerated periapical inflammation, and it's a dense collection of inflammatory cells, including the macrophages, and this appears to block the apex from any further infiltration of cells, which are critical for the regenerative endodontic outcome. Now, restoration of the disease pulp is achieved by the migration of the cells and the vasculature from the periapical region. And the focus of regenerative endodontic research is to facilitate this complex process by priming the intracanal and the periapical environment, making them ideal for the formation of the immune responsive tissues that are or could constitute the original biological structure and function of both pulp and the periradicular structure. And like many treatment techniques requiring optimization, The author recognized that in regenerative endodontics, it is important to consider the mechanical instrumentation technique of the root canal and the enlargement of the anatomical apex. Again, they refer to the recent research that has provided a new insight into the pathological mechanisms underlying periapical inflammation. And they refer to the Franceschi et al. 2018, Hirei and et al. 2018, Weber and Zhang 2018 and 2015, where they elaborate about the apical pathosis which develops in response to the upregulation of the pre-inflammatory cytokines that trigger an increase in the ratio of the pro-inflammatory, specifically M1 macrophages in relation to the M2, which is like anti-inflammatory macrophages. And this resultant inflammation, or with this resultant inflammation, cytokines can regulate the osteoclastogenesis, which can trigger the inflammation necessarily for bone and root resorption. Again, in the introduction part, they mention clearly what they are aiming for, or their goal was to assess in vivo the effect of mechanical enlargement of the anatomical apex on the intracanal cellular infiltration, bulb regeneration, and the role of periapical inflammation. In addition, they want to assess if the effect differs across different three-canal obturation materials. The author's data suggests that irrespective of the obturation materials, which I will cover through the material and method, the traumatic aspect mechanical instrumentation led to an exaggerated inflammation that termed inflammatory block. This appeared to block the apex from any further infiltration of the cells critical for the regenerative endodontic outcome. Okay, in the material method, they conducted the study conducted using mandibular first molars and third and fourth premolars from two 13-month-old female beagle dogs. They did the root canal treatment under general anesthesia in the mandibular third and fourth premolars, where they were being isolated by a rubber dam supported by the clamp. To ensure a sterile environment, teeth were scrubbed with betadine, and further isolation was maximized by the silicone rubber-based impression material. For each tooth, the apex was determined using stainless steel K-type files guided by a Nomad Pro handled X-ray system on Orgonom X self-developing dental film. But what attracted my attention there, they didn't use any apex locator. So mainly for the determination of the apex, they used the K file with the X-ray, which was confirmed by the radiographical image. The canals were prepared and pulp tissue extirpated with nickel titanium rotary pro-taper next files, but it wasn't clearly mentioned to what size and to what apical extent. The apex was opened to size O 54 millimeter by removing 1 millimeter from a size 5004 taper profile nickel titanium. So they used another rotary system in addition to the pro-taper next files. Canals were cleared of debris using 0.5 sodium hypochlorite and the 17% ADTA solution. The canals were dried with a sterile paper point, and the apical bleeding was induced using size 15K file into the periapical tissues. Before material implantation, it wasn't clear the blood was subbed to what level within the root canals. So now this is the experimental group. If you still remember, they used 12 roots and 6 teeth. So they divided into the following experimental groups. So the first group, where they have 2 teeth, or in another word, 4 root canals, where they induce apical bleeding alone with the collagen sponge, MTA, and the glass ionomer cement. The second experimental group, again, 2 teeth with 4 root canals, where they induce apical bleeding and they use the PRF, the fibrinogen, with MTA and the glass ionomer cement. The third experimental group, they use 2 teeth, 4 root canals, again, where they induce apical bleeding with blood clot and the MTA alone, without the use of collagen sponge like the first group, and again with MTA and GIC. Each root represents a separate treatment entity, and this will be more clear when I cover the histological slides. Dogs were subjected to 3-day analgesic and 7-day antibiotic. All animals remained healthy and active until sacrifice at 8 weeks. And then they had the microcomputed imaging, histology, and immunohistochemistry. All the 12 canals and the results were instrumented following the same protocol. However, 4 out of 12 canals had the sign of inflammation, which was attributed to accidental over-instrumentation. The remaining 8 root canals, there was sign of pulp regeneration with no inflammatory action in the periapical area. This finding was consistent across all the obturation material that been used, and the observed regenerative tissues were highly cellular through the whole length of the root canal. By contrast, when inflammation was there, or in other words, manifested as an inflammatory plaque that filled the apical foramen, bone and root resorption were noted, and there was no sign of regeneration or even a cellular infiltration beyond that inflammatory plaque. Now, this is the histological slide. Different outcome in multiple roots from the same premolars, 12 weeks after the root canal manipulation. Now here, if you can see, in the distal root, it was manipulated beyond the apex and showing an apical inflammation. Okay, it's obvious here there is more, still it's an apex, no any sign of closure, heavily infiltration, inflammatory infiltration there, root resorption, and no intraradicular cellular infiltration. However, in the mesial root, where the manipulation was within the root canal apex, and it shows no sign of periapical inflammation, intact root and BDL, intraradicular cellular infiltration, and regeneration. Again, we can see the micro CT images and the trichrome histology slides, and even the immunohistochemistry, which all with the associated protein CD86 in the periapical tissues in the distal and the mesial, and it shows the how the different canals responding differently with when the instrumentation was confined to the root canal system compared to the distal canal, where there was an extension of the instrumentation. This is where there's this histological slide represents the group which has only the blood clot. This is the group representing the 2 other obturating material using the collagen material and the fibrinogen. Again, those canals where the instrumentation was confined within the root canal space, it has like more favorable responding in terms of the closure, in terms of absence of inflammation, and even the presence of intra-space or intracanal proliferation of the cells, where there was no sign of any intracanal proliferation in the mesial canal where the instrumentation was manipulated beyond the apex. Again, the same response with the fibrinogen in the other group of the teeth. In the discussion, it was written that the author did not assess the differences between the regeneration process associated with the blood clot augmented with the IRF fibrinogen or collagen relative to a blood clot alone. A comparison addressed in the regenerative endodontic literature. Instead, this work focused on analyzing the biological response of the apex and the cell within the periapical tissues. The author also acknowledged that cementoid or osteoid deposition is not a desirable outcome. However, the presence of these deposits indicates a suitable environment for the migration of the mesenchymal stem cells from the BDL and their differentiation into the cementoblast, osteoblast phenotype will function similarly to the periodontal tissues. The presence of the cementoid deposition within the canal promote a discussion of a requirement to include cementogenesis inhibitor molecules during the dental pulp regeneration procedures. Nevertheless, the absence of signs and symptoms of inflammation and the presence of immunocompetent tissues, regardless of whether that tissue is true pulp, suggests that a regenerative or rather a reparative endodontic procedure still may be successful. In this study, the author underscored the effect of the periapical inflammatory plaque on cellular infiltration into the root canal. Cell homing within an empty root canal is critical to the initiation of the autologous regeneration of the dental pulp tissue. And they conclude that trauma resulting from excessive manipulation of the periapical BDL stimulates an aggressive inflammatory response. This was evidenced by the high presence of the M1 macrophages content adjacent to the root surface. This response led to the formation of inflammatory plaque and root resorption. So indeed, when the integrity of the periapical tissues was maintained, a regenerative environmental with cellular infiltration will be created along the root canal. Which is the modified apexification procedure for immature permanent teeth with a necrotic pulp apical periodontitis. Now, we all know the drawback of the traditional apexification of the calcium hydroxide old apexification versus the MTA and the biodentine apexification. In traditional apexification, the MTA or the biodentine plug used to be placed close to the open apex. And most of these cases, the continued apical root development usually will not occur. A regenerative endodontic procedure has the potential to promote thickening of the canals or even a continued root development for immature teeth with necrotic pulp and even with apical periodontitis. American Association of Endodontic Clinical Consideration, they state that a regenerative endodontic procedure is indicated whenever the pulp space is not needed for the post-core final restoration. The concept of the modified apexification was developed to potentially promote the continuation of the apical root development of immature permanent teeth with necrotic pulp and apical periodontitis, and they have suggested criteria for this type of procedure, and mainly where the for teeth have lost substantial coronal structure, where there is a need for post and core. Also for the teeth at stage 3 and 4 of root development, where the modified apexification can be an alternative treatment to the traditional apexification to encourage the continued root development. Now, the modified apexification procedures in general, they advise the use of the local anesthesia, 2% lidocaine containing 1 to 100,000 of epinephrine. The canal can chemomechanically debride it to ensure the disruption of and disinfection of the bacterial biofilm using 3% sodium hypochlorite, where they can place a 3 millimeter thick resorbable collagen matrix placed in the 1 to 2 millimeter from the open apex to prevent the extrusion or even the biodentine extrusion into the MTA and biodentine into the periapical tissues, where they can place a thick 3 millimeter thick MTA or even a biodentine plug over the collagen matrix. The rest of the coronal canal space can be backfilled with the warm gutta-percha using the vertical compaction technique, and then the access cavity can be restored with the permanent restorative materials, and the collagen matrix in the apical canal will eventually be resorbed, leaving 4 to 5 millimeter of the apical canal space unfilled for the continuation of the apical root development. Now, for this apexification method, there is no need to rinse the canal with the ADTA, or even no need even to induce a periapical bleeding into the apical air canal, as it's used for the regenerative technique. So again, they advise the placement of 1 to 3 millimeter collagen away from the apex by 1 to 2 millimeter. MTA or biodentine, again, 3 millimeter can be placed over the collagen matrix, and then the rest of the canal backfilled with the gutta-percha. In the present case series, where the 10 immature permanent teeth with necrosis, bulb and apical periodontitis were treated, they used again local anesthesia using 2% lidocaine and 1 to 100,000 epinephrine. The teeth were isolated with the rubber dam. Access cavity were prepared through the lingual surface of the anterior and the occlusal surface of the posterior. The bulb chamber was irrigated with 3% sodium hypochlorite. The working length of the canal was determined with the hand K file root ZX apex locator, and then was confirmed with the conventional periapical radiograph. The canal was chemomechanical debrided with hand K files and pro-taper universal rotary files to an appropriate size to disturb bacterial biofilm on the canal walls. In the first visit, all canals were irrigated, as I say, with the sodium hypochlorite and dressed with the calcium hydroxide. And then the access cavity was closed with the cotton pallets and the intermediate restorative material for 2 weeks. In the second visit, if the tooth was asymptomatic, the access cavity was reopened, calcium hydroxide removed. The canal was dried with paper point without ADTA irrigation, and also no need to induce intracanal bleeding. A biocompatible resorbable collagen again was placed with the appropriate Buchanan hand pluggers. And then the whole thing was covered with a 3 millimeter thickness of the MTA or the biodentine. Radiographical images were taken to check the placement of the MTA or the biodentine plug, and the rest of the coronal canal space was filled with the worm gutta-percha using the vertical compaction technique, access cavity restored with the final temporary restoration. However, if the tooth was symptomatic, another round of chemomechanical debridement and calcium hydroxide dressing was performed until the tooth became asymptomatic before the completion of the modified apexification procedure. The treated teeth were reviewed at 3, 6, and 12 months, 2 years, and up to 4 years. Now, in the result, 10 cases of the immature permanent teeth with necrotic pulp apical periodontitis, they had a minimum of 2 years of follow-up. All 10 cases had no clinical symptoms or even signs of any problems or any failures, and showed radiographical evidence of healed periapical pathology. 8 cases showed increased thickness of the apical canal walls, increased apical root length and apical closure, and 3 cases showed diffused intracanal calcifications. The overall percentage change in the root length was 7.52. In root width at the apical 1/3, it was 18.89, and in the other group, it was 15.04 at the 24 to 72 month follow-up period. Now we will see now the radiograph. This radiograph showing the first case, and it refers to tooth number 8 and 9. Tooth number 8 had an open apex with a fracture of the incisal 2/3 of the tooth, where the tooth number 9 had a slight widening of the BDL. The modified apexification was carried out in tooth number 8, and it shows here the if you look at the radiograph or in the B here, a post-operative periapical radiograph after the modified apexification procedure, while in C, periapical radiograph of the 4-year follow-up of, again, tooth number 8, and it's obvious that the periapical lesion healed completely with a diffused intracanal mineralization of the apical root canal and with the apical closure, while tooth number 9 was treated with root canal therapy because the apex was closed. This is another case where you can see the preoperative periapical radiograph of tooth number 9. The tooth had a complicated crown fracture, has an open apex and a periapical lesion. Clinically, the tooth was diagnosed with necrotic pulp and asymptomatic apical periodontitis. In B, you can see a periapical radiograph of the same tooth 2-year follow-up and showing resolution of the periapical lesion and even an apical closure. In C, you can see also the it shows a complete healing. Now, in the third radiograph here, it shows the periapical radiograph of tooth number 31. The crown has a large temporary filling. The distal root had an open apex. Clinically, the tooth was diagnosed with irreversible pulpitis with symptomatic apical periodontitis. And the distal root here, it shows again the healing of the periapical area and even a closure here of the same root treated by the modified apexification. Now, in the discussion, they refer to the Hertwig epithelial root sheath, and where they provide an inductive signal to the stem cells in the apical papilla to differentiate into odontoblast and produce the root dentine. Also, they can signal the stem cells in the dental follicle to differentiate into the cementoblast and produce the cementum through the epithelial mesenchymal interaction. Therefore, they are responsible for an increase in thickness of the canal walls, length of the root, and even the apical closure. So if any damage affects the Hertwig epithelial root sheath, either through a persistent apical periodontitis or through a physical irritation during the induction of periapical bleeding, continued root development could be halted. Usually, healing of the arrested root of immature permanent teeth with necrotic pulp, apical periodontitis after regenerative endodontic procedure is by repair and not regeneration. Wound healing is a continuum and even a sequel of inflammation, and it's the host programmed response. Wound healing is to recapitulate the event of embryonic tissue morphogenesis, and it requires spatial and temporal orchestration of certain cells, matrix, and bioactive growth factors, cytokines, and chemokines. And during the wound healing, the wound will be filled with granulation tissues as a part of the programmed wound healing. In this type of apexification procedure, the apical canal space can be easily filled with granulation tissues from the inflamed periapical tissues, even without induction of the periapical bleeding into the apical canal space, if the canal foramen is large enough. Now, the progenitor cell from the apical bone marrow, from periodontal ligament as well, and even from the apical papilla, all can migrate and proliferate into the apical root canal space, differentiate into cementoblast, osteoblast, or odontoblast, and all together can produce cementum-like, bone-like, or even dentine-like tissues in certain cases, similar to the tissues formed in the canals after regenerative endodontic procedures. Now, vigorous induction of bleeding into the canal can damage the Hertwig root sheath and prevent the root growth. In the modified apexification, only the apical 4 to 5 millimeter of the space is empty after the chemomechanical debridement. So the Hertwig root sheath epithelial is protected to some extent from any damage. Therefore, induction of bleeding might not be necessary. However, chemomechanical debridement was used in this type of apexification to help disturb and disinfect intracanal bacterial biofilm, and all the 10 cases included in this case series had complete periapical healing. The infection control measurement of the infected using this type of debridement with the calcium hydroxide intracanal medication was effective. Now, the type of the tissue formed is not known without histological examination. So there is a need for a further histological examination to clarify the exact type of hard tissues formed within the canal after the use of the modified apexification. However, increased thickness of the apical root canal wall and diffuse mineralization, as I showed in the radiographical images, it indicates that mineralized tissue-forming cells have migrated into the apical canal space to form the mineralized tissues in this type of apexification procedure. Apexification, where we used to place the MTA or the biodentine close to the open apex, usually does not promote continued root development, and this could be because of the high pH, which goes to 12.5 of the MTA or even the biodentine altogether can damage. Remember, this can damage the Hertwig epithelial root sheath and the apical papilla cell altogether can affect the root development. An advantage of this modified apexification is that the coronal aspect can be used with either a boost or even a composite resin placed inside the canal, and it's recommended to be carried out in teeth with stage 3 and 4 of root development. In conclusion, the modified apexification procedure is easier than the traditional apexification procedure. In addition, the modified apexification procedure has potential to promote continued apical development, thus increasing the crown-root ratio. Again, immature permanent teeth with necrotic pulp at stage 3 and 4 development requiring sometimes intracanal post-core for final restoration, and this can be easily executed in the case with the modified apexification procedure. And more prospective controlled clinical trials are needed uh, to, to, uh, to verify the use of the modified apexification procedures for the immature teeth, to find out even histologically the type of tissues being formed there uh, after this type of apexification. Now, let's move to the next article, which was published by Ran et al. In the International Journal of Endodontics, again 2020, which related to the effect of the length of apical root resection on the biomechanical response of a maxillary central incisor in various occlusal relationships. Now, several heterogenic factors, such as root perforation, ledge formation, or any instrumentation-related procedure errors that need to be corrected surgically. Apicoectomy is an effective treatment that can be carried out to correct either the procedure errors or even to remove most of the infected anatomical structures and to repair, as I just said, the procedure errors in the apical third of the root. Now, root resection altered the crown to root ratio, which is a critical prognostic factor and can affect the tooth longevity. Crown to root ratio has been used in the specialty of the prosto and the perio, and they might refer to a different definition, might be not directly related to our procedure, specifically the root end resection. Classically, 1 to 1.5 and even 1 to 1 of crown root ratio is suggested as an acceptable value for fixed partial denture abutment. And most studies that have investigated the crown root ratio mainly targeted the teeth with periodontal disease. Now, the coronal root surface area is greater than the apical region of the same length. As a consequence, the crown root ratio value based on periodontal bone loss is not applicable to apically resected teeth. Again, apical surgery might decrease the root length and the periodontal support, which might affect the stress distribution or even increase the tooth mobility and subsequently influence the tooth function and the tooth survival. Sometimes more extensive root resection is required clinically. Now, we all agreed that the ideal root resection is 3 millimeter, but sometimes we might extend to 4 millimeter or even more due to the existence of the perforation, resorption, or root fracture beyond that 3 millimeter, which is ideally accepted for the root resection. Various occlusal relationships, such as deep overbite or increase overdit, all can alter the occlusal contact area or even the angle of the force. Altogether influence the biomechanical response, namely the stress distribution and the tooth displacement. And this can make the situation even more complex. Deep overbite and increased overjet or correlated with a greater rate of external apical resorption in maxillary incisors. So the study aimed to compare the influence of various root resection lengths and occlusal relationship on the biomechanical behavior. So they have two hypotheses to investigate. If the various lengths of apical resection and intact teeth have the same degree of biomechanical change, in another word, the stress distribution and the tooth displacement in the same occlusal relationship. And the other hypothesis to investigate if the same length of apical root resection associated with the same degree of biomechanical change in the various occlusal relationships. They used, or actually they developed finite element models of a sound maxillary center incisor, which is a method for numerically solving differential equation, widely used in engineering and in mathematical models. And this is what we mean by the finite model. They used for this model a sound maxillary central incisor, which was donored by a 29-year-old man who had suffered an avulsion. The crown of the tooth was 12 millimeter long and the root was 13 millimeter. And the tooth was scanned using microcomputed CT scan. And then they create a 3D model using a unographic NX software, which is a advanced high-end CAD/CAM to have an intact 3D model. In addition to the intact model, they had another model which was developed. So this is the intact model, and they have another model with an apical root resected and complete healing, which was used for another study, Young, 2018. So for this material method, they have an intact model and a resected or apical resected model, where the resected model, they had a root canal treatment, an obturation, and a resection of the apical part with a 3 millimeter resection, and even with a root end prep and even an MTA, which has been used as a root end filling material to create the apical root resected model. For the completely healed model or the root resected model, they create 5 extra models to various root resected length, 4, 5, 6, and 7, and 8. This gives in total 7 models were included to investigate the biomechanical influence, as I said before, the stress distribution and the tooth displacement of different lengths of root resection. As I said before, they used the finite element system. And for each model, under different loading condition, they measure the maximum stress at the root apex, at the root surface, at the alveolar bone, and the periodontal ligament, and even the tooth displacement. And all these data or values were calculated for each model respectively. Okay, from Yang, they adopted 2 equations to end up with this table that represent a fixed crown root ratio, giving an ideal crown root ratio for every type of occlusion with every level of root resection. Okay, so from Yang, they already have 2 formulations or equations where they divide the clinical crown length. If you still remember where I mentioned this in the material method, in the first part of the material method, the crown of the tooth was 12 millimeter long and the root was 13 millimeter long. And these calculations will give these figures or numbers for the crown root ratio in with different type of occlusion and different level of resection for the normal occlusion and for the increased overjet, while this equation was practiced or carried out for the cases where there is a deep overbite or deep overbite with increased overjet occlusal relationship. This figure explains the type of occlusion. For the normal occlusion here in figure A, it shows the normal occlusal relationship where a static load, 100 Newton, was applied at an oblique 45 angle to the longitudinal axis of the teeth on the palatal surface of the crown, close to the incisal edge. So this represents the normal occlusion. In the B, for the increased overjet, the same load was applied to the same blades close to the incisal edge, but at a 60 angle to the long axis of the tooth. In C, for deep overbite, the static load was applied to the middle of the palatal surface. It's not close to the incisal edge as it's the case in the A, but it's closer to the palatal surface at a 45 angle, while in D, for the deep overbite with increased overjet, the same load was applied to the middle of the palatal surface at an angle of 60 degrees. For the result, it was found that the loss of periodontal ligament increased massively as the root resection increased. When more than 6 or 8 millimeter root resection, the loss of periodontal increased to more than 30 to 50% respectively. In normal occlusal relationship, the maximum stress values of the surfax and the periodontal ligament and the alveolar bone increased whenever the root resection increased. Now, when 8 millimeter of apical root resection was stimulated, the maximum stress at the surfax, periodontal ligament, and alveolar bone all increased respectively to these figures compared with the preoperative. The displacement value also increased as the resected normal length increased. Remember, this is when we have a normal occlusal relationship. This is the finite element model. It shows here the stress distribution of the tooth. In case of normal occlusal relationship, you can see where's the stress distributed all over the root. But with the reduction of the root, it increased more cervically. In B, it shows here the, or actually it compares the stress and the displacement at the cervical part, at the periodontal, and at the bone, and it shows the displacement. And all the 4 parameters increase dramatically whenever we exceed the 4 millimeter of the root resection. Remember, this is a normal occlusal relationship. Now, for the increased overjet, the maximum stress and the maximum displacement were the highest with increased overjet. More than 5 millimeter of the resected root length caused the maximum displacement to markedly increase more than 10%. Displacement even can reach 23.4% when the resected root length can increase to 8 millimeter. When 8 millimeter of apical root resection was performed, the maximum stress it can go up to 45 in the cervical part, 33 to the periodontal ligament, and even 54.5 in the alveolar bone compared to the preoperative. And the maximum stress at the root apex increased to 163 compared to before root resection. This is again the result of the finite element model. It shows again here how the stress was distributed all over the root surface, and whenever we increase the level of the root resection, it will be more concentrated cervically. And again here, when we compare the maximum stress with the displacement along the root surface, along the periodontal ligament, within the alveolar bone, and the displacement, again the figures, obviously it increased dramatically for after the 5 millimeter of root resection. And here it shows the stress concentration at the root apex after the resection, at the resected root and within the intact tooth. It shows even how the stress can increase after the root resection in comparison in the intact root canal. Now for the deep overbite, the stress maximum concentration and the displacement were the lowest in the deep overbite. The stress maximum increase in alveolar bone, and it can go easily to 50% when the root resection goes to 5 millimeter. This can even increase to 104.20 when we increase the root resection to 8 millimeter. The stress max, or the maximum stress of the periodontal ligament, again can increase to 50% when the root resection increased to 6 millimeter. And the stress maximum value at the root apex as well can increase to going to 163 if we compare it to the root before the resection. Displacement maximum values of the resected root models decreased compared with the preoperative status, except the 8 millimeter. For the deep overbite, again it shows how the stress is concentrated in the cervical area and this part of the bone. And here, if you remember the articulation of the teeth in the deep overbite and how the stress can be concentrated or directly to the area of the middle of the palatal surface, it explains why the stress mainly concentrated in this part of the cingulum and the corresponding area of the bone. And again, all the figures can increase dramatically whenever we exceed the level of the 3 millimeter root resection. Deep overbite with increased overjet. The maximum values of stresses at alveolar bone increased markedly, more than 50% when the resected root length was 7 millimeter, and it can reach to 80 when the resected root length increased to 8 millimeter. The stress maximum values at the root surface gradually increased, reaching 42 when 8 millimeter was performed, of root resection was performed. The maximum stress values at the periodontal ligament increased slightly when the root resection was more than 3 millimeter. And the stress maximum values of the root apex increased to, again, 169.68 compared to the root before the resection. And the displacement values of the 3 and 4 millimeter resected models were decreased compared with their preoperative status and increased gradually when the resection reached 5 millimeter. Again, this is the finite element model representing the teeth with the deep overbite with increased overjet. And in the periapical surgery, it was clearly mentioned in the discussion the effect of the periapical surgery and how can it alters the root length, which can even change the stress distribution and the tooth mobility. Altogether can affect the longevity or even the survival and the functioning of the resected tooth. The present study simulated the process of root canal treatment and root end resection and revealed that at various root resection lengths, affected the biomechanical response, and because of this, they reject the first null hypothesis. In all occlusal relationships, maximum stress at the root apex, at the surface, at the alveolar bone, and at the periodontal ligament, and the maximum tooth displacement all increase as the resection length increased. When the static load was applied to the crown, okay, without root resection, the maximum stress occurred in the cervical area, whilst the minimum stress were found in the apical area. And this is consistent with the previous studies mentioned in the introduction and the discussion part of this article. And they explained this because when the masticatory forces are applied, the root surface act as a fulcrum. So the stress concentrates at the surface and this part of the alveolar bone. Under the same load condition, when the root resected, it become as it is become shorter with the root resection, the stress distribution at the surface and the alveolar bone increased. Meanwhile, the root apex and the alveolar bone act, in this case, it will act as a second fulcrum. Surface area of the coronal part of the root is larger than that of the apical part. And according to Levy and Wright, the coronal half occupies 61.5% of the root surface, whilst the apical half occupies 38.5%. Pulp also reported that 3 millimeter loss of apical support is equivalent to 1 millimeter of costal bone loss. What is more, masticatory forces are concentrated mainly at the cervical area. Therefore, the increased crown-root ratio caused by apical root resection induces less stress concentration compared with periodontal bone loss. With the various occlusal relationship, different prognosis after root resection can result. In the present study, the stress of all tested structure and the maximum tooth displacement values were highest with the increased overjet. This was followed by the normal occlusion, an increased overjet with the deep overbite, and the lowest values were found in the deep overbite. This probably due to the loads being applied at an angle of 60% from the long axis of the tooth, which means that the larger force was perpendicular to the tooth long axis, and this situation caused larger stress concentration in the cervical area and alveolar bone, and accordingly, this can result into greater tooth mobility. Under increased overjet condition, more than 5 millimeter of root resection, increased tooth mobility can result. For deep overbite, reduction more than 4 millimeter should be undertaken with more care for teeth with large especially with teeth with large periapical lesion or periodontal disease. In deep overbite with increased overjet, more than 6 millimeter of root resection is contraindicated during apical surgery. Crown root ratio should be calculated not only from only one-dimensional measurement, and it's not directly proportional to the three-dimensional alveolar bone support. Compared with the crown root ratio, the supported periodontal surface is more appropriate to reflect the alveolar bone support. In conclusion, the various root resection lengths altered the biomechanical response of the maxillary central incisor. And remember, this tooth was sponsored by a man who is 29 years old and from a Chinese population. A larger crown root ratio resulted in more unfavorable stress distribution and tooth displacement. The root resection length should be determined by the individual occlusal relationship. In increased overjet or deep overbite, the clinician should be more conservative and not resect the root too much. Further clinical studies are needed to verify the influence of root resection and to supplement the limitations of this finite element analysis study. Let's move to the last study for this presentation, which was a study published by the Plumpton et al. Group, which was published in Saudi Endodontic Journal in January to April 2020. And they refer to the in vitro cytotoxicity of some hemostatic agent used in apicoectomy to human periodontal ligament and bone cells. Various hemostatic agents have been used in the periapical surgery, and they generally classified as mechanical, chemical, biological, and even resorbable agents. These agents or chemical agents, such as aluminum compounds and ferric sulfate, they have the mechanism of action of protein precipitation. Protein precipitates from these chemical agents can create foreign body reaction that can complicate the healing. Also, tranexamic acid is a synthetic derivative of the amino acid that can work through the antifibrinolytic effect, which can reverse the blockade of lysine binding sites on plasminogen molecules, and it has been used as a mouthwash to prevent the bleeding in patients taking warfarin who require dental extraction or oral surgery. Clinically, the hemostatic agent is applied directly to periodontal and bone tissues. These agents should be non-toxic to these cells and tissues. So therefore, a cytotoxicity test is necessary to determine if this agent has minimal toxicity and is appropriate in the endodontic surgical procedure. So the purpose of the study was to test the cytotoxicity of the hemostatic agent used in periapical surgery and to mainly primary human periodontal and bone cells. Now, they had the patient recruitment of patients who ranged in their age from 18 to 25 years for routine extraction, where they get the periodontal tissues, cells, and bone cells. For the periodontal, human periodontal cells, they obtained it from non-pathologically impacted third molars with mature roots. While for the bone cells, they get it from the bone chips, from healthy patients again, who ranged in their age from 20 to 60 years, who required alveoloplasty, torus platinus, or torus mandibularis removal for prosthodontic reasons. For the primary cell culture, they just, as I just explained, were obtained for the primary human periodontal cells were obtained from extracted teeth, where the human bone cells were obtained from bone chip. Both lines of cells, they reached the confluence. They had a further subculture, and all experiments were performed, at least in triplicate, using cells prepared from 3 different donors. For the hemostatic agent in this experiment, They used the epinephrine, aluminum chloride, aluminum sulfate, ferric sulfate, and tranexamic acid. They have also another group, they call it the regular negative and positive group, where they use medium and sodium hypochlorite, regular complete medium and sodium hypochlorite, to represent the positive and the negative control group. The initial concentration of the epinephrine and from the ferric sulfate and from the tranexamic acid, 0.1, 31, and 10, respectively, where they had further serial dilutions. Stock solutions of 30% aluminum chloride and aluminum sulfate were diluted to concentrations of 25, 20, and 15 and 10%, while for the 5% sodium hypochlorite used as negative control, they diluted it to 2.5, 1, and 0.5%. Now they carried the MTT cytotoxicity assay, where the human periodontal cells and the human bone cells were seeded into the 96 wall plates, where the cells were exposed to each of the hemostatic agents at different interval time, 1, 5, and 24 hours. They checked the cell morphology with the microscope. They checked the cell viability with the colorimetric qualification, which is the MTT cytotoxicity assay that looked at the mitochondrial metabolic activities. The mixed solution was measured using the spectronanometer, which has an absorbance of 550 nanometer. And then they came up with a specific optical density for each dilution. This was carried out for the positive control as well. And then they had a criteria to examine or to test the cytotoxicity. For criteria for the non-toxic group, whenever there is more than 90% of cell availability or viability. Slightly toxic when they had like 60 to 90% of cell viability. Moderately cytotoxic when there is 30 to 59 cell viability, and severely cytotoxic when there is less than 30% cell viability. They looked at the morphology of the human periodontal cells and the human bone cells going under the different dilutions of the hemostatic agents. And they found that under the microscope, there was a mixed population containing spindle-shaped and polygonal-like cells. The only normal cell configurations were observed with the epinephrine tranexamic acid group. These two groups, this group representing the epinephrine, this group representing the tranexamic acid, which is really close to the culture medium positive control. While in C, D, and E, you can see obvious how the protein precipitate obscured the cell morphology, and this was the case with the aluminum chloride as it is in C, aluminum sulfate as it is in D, and the ferric sulfate in E. To make it more clear again how it's look normal in epinephrine and in the tranexamic acid, which is very close to the culture medium. Cytotoxicity of the hemostatic agent of both human periodontal cell, ligament cells and the human bone cells, where the pattern of the response was similar and tended to be dose and time dependent. However, it was noted that the human bone cell were more resistant to the agent compared to the human periodontal. Here you can see more clear. Now, this is the cell viability under the different concentration of the epinephrine, and this diagram represents the behavior of the human periodontal cells and the behavior of the human bone cell. When I just explained how the human bone cells were resistant, it's obvious how it goes in a linear direction rather than the reduction here going in the case of the human periodontal cells. So this is why this is what they mean by the human bone cells were more resistant to most of the hemostatic agents, as it shows here with the epinephrine and the aluminum chloride. This goes again with the other hemostatic agents, namely the aluminum sulfate, the ferric sulfate, and the tranexamic acid. And it's obvious here how the influence goes with or depend on the dose. Whenever we increase the dose or the concentration, the influence is clearly decreasing the viability. But again, the human bone cells were more stable or more resisting the effect of the hemostatic agent, even through different concentrations. Again, this is another figure, and it shows the different time how the cells behave with different hemostatic agents with time. At 1 and 5 minutes, both epinephrine and tranexamic acid were slightly toxic to the human periodontal ligament cells, but non-toxic to the human bone cells. At 24 hours, they were highly toxic to the human periodontal cells, but moderately toxic to the human bone cells. This is obvious or clear message why we need to clear the materials from our osteotomy before the closure of the flap, or even before adapting the flap. And it shows from these figures that the tissues can, or the hemostatic agent can be highly toxic to both cells, and this effect can continue even up to 24 hours. And even with the most moderate hemostatic agent. With the aluminum chloride and aluminum sulfate, at 1 and 5 minutes, both aluminum chloride and aluminum sulfate had moderate toxicity to the human periodontal cells. At 24 hours, both agents highly toxic to the human periodontal cells, and at all time, both agents were moderately toxic to the human bone cells. For the ferric sulfate, at all time points, ferric sulfate was highly toxic to both the human periodontal cells and even toxic to the human bone cell, but to a moderate level. Cytotoxicity, as I just said, of all hemostatic agent was time and concentration dependent. So remember, we have to eliminate all the hemostatic agents from the osteotomy, as this reaction can continue even up to 24 hours. Epinephrine and tranexamic acid had mild or no toxicity to both human periodontal and bone cells at all time points. Aluminum chloride, aluminum sulfate, and ferric sulfate were moderately to highly toxic to all the cells. No significant difference was found between epinephrine and tranexamic acid. MTTSA was used in the study to measure the cytotoxicity, where the various hemostatic agents were exposed or to the cells. And this MTTSA is a colorimetric method. It measured the cell metabolic activity based on the ability of mitochondrial succinate to dehydrogenase and to reduce the tetrazolium salt to its insoluble crystals, and this is why it has a purple color. This type of assay is a quick and reproducible and reliable to assess the cytotoxicity of the different materials, and thus may be considered as the gold standard for cell viability. Considering the clinical concentration of these hemostatic agents at 1 and 5 minutes, epinephrine was the least toxic. Due to its excellent hemostasis, epinephrine should be considered as the first choice in the periapical surgery. However, remember there might be some risk, especially for the cardiovascular patients, and even in patients with underlying cardiovascular disease. The amount of epinephrine for used for hemostasis in endodontic microsurgery is 0.2 to 2.4, which is much higher than other dental surgeries. So we might think about alternative hemostatic agent in those patients. And both aluminum compounds, which is like the aluminum sulfate and the aluminum chloride, ferric sulfate as well, have been successfully used in hemostatic agent, but based on this, the finding of the study, they are quite toxic. At 1 minute and 5 minutes, aluminum chloride and aluminum sulfate were moderately to severely toxic to both type of cells, but ferric sulfate was highly toxic to the human periodontal cells. This is in vitro study that may be a useful preliminary screening method. However, an in vitro study cannot provide data that are directly applicable to human. However, I need to elaborate a little bit about this type of procedure. Now, cell culture is a promising alternative to animal use. And before a new pharmaceutical or surgical can be introduced on the market, it has to be tested on humans during clinical trials. The purpose of animal testing is to safeguard the health of the people taking part in these trials. The vast majority of the drugs initially selected for development are rejected during this process. So sometimes it might be helpful to examine any new chemicals or any new drugs using the cell-based procedures, especially on the cell lines taken from the human beings, because it might be more related or it gives more related information compared to the studies that might be carried in animals. Therefore, the application of this study in vivo should be further investigated. In addition, further studies are also needed to investigate the hemostatic potential of different concentrations of tranexamic acid. Epinephrine and tranexamic acid tended to be non-toxic or mildly toxic to periodontal ligament and bone cells. Both of them might be considered as the appropriate hemostatic agent for surgical endodontic. Thank you. This is the end of our presentation, if I can say today. And those who are interested, you can go and double check this presentation, as it's going to be published and downloaded in the social media account of the Saudi Endodontic Journal. Thank you.